Good evening, everybody. My name's John Isaacs. I'm from Newcastle University in the United Kingdom. Really pleased to welcome you tonight. Thank you for joining us. We've got a really interesting and I think a fairly unique session tonight, talking about BTK inhibitors in rheumatology. Apart from myself, I'll introduce the faculty briefly. We've got Ed Vital, who's Associate Professor in Autoimmune and Connective Tissue Diseases at Leeds Teaching Hospitals NHS Trust. David Eisenberg, who's Professor of Autoimmune Rheumatic Diseases at University College Hospital, UK. And Stanley Cohen, who's Clinical Professor at the University of Texas Southwestern Medical School from the USA. So just before we start, a little bit of housekeeping. You'll be on mute for the duration of the meeting, but I encourage you very strongly to submit your questions at any time through the Q&A function. So don't just wait till the end. If you have a question in the midst of a talk, just put it in the Q&A function and we will keep it there for you. If you've got any questions or having any technical difficulties, use the chat box, but do put your questions in the Q&A, not in the chat box. It's only that if you've got technical difficulties, you can use the chat box. And just so you understand, all the questions we will do right at the end of the three talks, but that's why we like you to put the questions in as we go through. So this is the program for this evening. After this very brief introduction, Ed's going to talk to you about the Bruton's tyrosine kinase pathway as a potential target for autoimmune disease therapies. David will then talk to you about data from SLE. Stan will then talk to you about data in rheumatoid, and then we will have a discussion before we close down in about an hour's time from now. So without further ado, I will introduce you to Ed. So Ed Vital, I've already mentioned, is an Associate Professor in Autoimmune and Connective Tissue Diseases and an Honorary Consultant Rheumatologist at Leeds Teaching Hospitals NHS Trust in the UK. He's also the head of Lupus Research Group with interests in early disease, skin disease, musculoskeletal outcome measures, translational immunology, and B-cell therapies. So again, remember, do put your questions in the chat as Ed goes through his talk, but now I'm going to hand over to Ed to give the first talk of the session. Ed, thank you for joining us this evening, and the floor is now yours.
Thanks. So this is just a very brief introduction to the BTK pathway, which will just lead into then the data you'll hear about the clinical trials in the following two talks. So I'm really going to try and explain what this pathway is and why that seems relevant to rheumatic diseases. So Bruton's tyrosine kinase is this cytoplasmic tyrosine kinase signaling molecule, and its main role that it's most well known for is in signaling through the B-cell receptor. So most of the clinical use that you'll see is predicated on that there are a lot of B-cell mediated diseases in rheumatology. But it is important to note that it does have a number of other secondary roles that could lead to other beneficial effects, or perhaps even could lead to some off-target toxic effects that we need to be aware of. So it does have roles in the signaling of other immune pathways in other cell types, and I'll show you those in more detail. But you can look at classes like the pattern recognition receptors that are important for the innate components of these diseases, like interferon production, the FC receptors that are important for the effects of pathogenic autoantibodies, and as well as some of the other cytokine and chemokine receptors. So just talking about what happens on B cells, first of all. So as you'll know, B cells then the main receptor for antigen, the B-cell receptor, is the same immunoglobulin for which they're programmed to produce, that's on their cell surface, with a subtype that varies according to the B-cell and according to its stage of differentiation. So that immunoglobulin on cell surface, for it to signal when it binds antigen and cause activation of the B-cell, you need this cascade of signaling molecules. And crucial to that are molecules, as shown here, things like Lin, Sic, and BTK having a crucial role. And when those signaling molecules get phosphorylated, you get transcription of a set of genes that result in the well-known effects on B cells, so proliferation, survival, autoantibody production, etc. In fact, in memory B cells, as you know, you get this rapid and stronger response in IgG positive memory B cells, and that's in part related to this pathway, because this is immunoglobulin binding tail tyrosine motif that gets phosphorylated by Syk and therefore recruits BTK. BTK does have some other roles in some other B cell signaling that should be familiar. So, for example, BAFF, we all know in the lupus world, is a really important therapeutic target. BAFF is this molecule that helps B cells survive and proliferate. And BAFF receptor can signal through non-canonical NF-kappa B, but also by the canonical NF-kappa B pathway by co-opting the B cell receptor pathway, as shown there. And that's also then via Syk and BTK, and also involved in B cell survival. And lastly, of course, B cells do have toll-like receptors themselves that they can directly respond to certain damage or pathogen molecules, antigens that they may see. And that's also relevant in some of these other cellular effects that are illustrated here. So as this is just showing some of the other non-B cell effects. So we talked about the B cell receptor and BAFF already, but BTK also has a role in signaling through the Fc gamma receptor. So wherever you've got an autoantibody, for example, activating a monocyte or a macrophage, that can involve Fc gamma receptors. Through toll-like receptors 3, 4, 7, 9. These can involve BTK signaling. These are sensed. So, for example, in the lupus field where I work, toll-like receptors 7 and 9, they detect nucleic acid antigens that we know are important in lupus and in triggering interferon production. BTK signaling has a role in the Fc epsilon receptor, which is the receptor for IgE, so therefore allergens and mast cells. IL-5 has a role in eosinophils, well known in the field of asthma, and in the inflammasome in these autoinflammatory diseases, IL-1 mediated diseases, and so on. So this table here is summarizing some of those different cellular effects that you can get from BTK inhibition, again, in another way. So B cells, proliferation, differentiation, immunoglobulin production, but B cells also present antigens and they can make some cytokines. You've got conventional dendritic cells, they'll be activated by the toll-like receptor 4, 7, and 9 with interferon production, cytokine production. Mast cells, so because of Fc epsilon as well as Fc gamma, so that would result in mast cell degranulation, like you get in allergy and some of the cytokines they produce. And neutrophils can be activated because of the GM-CSF, Fc gamma, NLRP3 effects on BTK signaling. So all the things that neutrophils do: maturation, degranulation, phagocytosis, inflammasome. Monocytes and macrophages, I mentioned the Fc gamma effects to autoantibodies as well as toll-like receptors. And there's also BTK signaling in osteoclasts. So it's involved in rank signaling, which we all know again in rheumatology well in the maturation and differentiation of osteoclasts. So now just a brief word on some of the evidence that we had that suggested it was worth blocking this pathway in human autoimmune diseases. So rheumatoid arthritis and lupus, you'll hear the clinical data that's already been done in more detail. So in rheumatoid arthritis, there was evidence that BTK knockout would protect against experimental inflammatory arthritis. And you could also see that the roles there were in B cells, but also there seemed to be beneficial effects on macrophages and osteoclasts. And in humans with rheumatoid arthritis, you could see a correlation between phosphorylation of BTK in B cells with other B cell biomarkers like rheumatoid factor levels. And there were in vitro data on the synovium to show that blocking BTK could reduce inflammatory cytokines. So then in other B-cell mediated diseases, so in lupus, similarly, there's animal data on BTK deficient or BTK inhibitor treated mice, similarly showing B-cell receptor effects, but also toll-like receptor and Fc receptor effects. And again, there's a correlation between BTK activity in B cells in blood and some of the clinical features of the disease, like lupus nephritis. And although again, you'll hear this in detail, but although whether the BTK inhibitor trials are positive or not, you always in lupus, it's always worth looking at the biomarker data as well to see what activity that drug does, given the complexity of the trials. And some of these other related diseases have some very similar suggestive evidence, as you'd expect. There's usually the drugs that work in lupus will have have plausible efficacy in Sjögren's syndrome of a very similar type, or in systemic sclerosis, some in vitro evidence there to suggest this might help on cytokines and on production of scleroderma-specific antibodies. And although we're not talking about these in so much detail today, to just briefly mention, as you'd imagine from this mechanism, there are many other potential diseases that could be candidates for this class of therapies. So any B-cell mediated disease should theoretically be a candidate. So here are some of them that have been investigated. So immune thrombocytopenia in early phase clinical trials, granulomatosis polyangiitis, we've got in vitro evidence that it might be helpful, and therapy in animals. Pemphigus, phase 2 and 3 trials, multiple sclerosis also in clinical trials. And then there has been some, because of these non-B-cell effects, there has been some interest in some of the non-diseases that we wouldn't think of as B-cell mediated. So psoriasis, there's some in vitro evidence, therapy in animals. Graft versus host disease, there's positive trials actually in some clinical use, and asthma and COPD, given those non-B-cell effects I discussed earlier, again, we've got therapy in animals. So just lastly, just to touch a little bit on the inhibitors. So BTK is a member of this TEC family of kinases, highly conserved, 659 amino acids long, 5 domains, 2 phosphorylation sites. So there are different sites where an effective inhibitor could bind. So of all the kinase inhibitors, there's more than 500 of them known and under investigation. So they get classed, most of them get classed as 1 to 5 based on where they bind to ATP binding pockets. That can be either in the active or the inactive kinase or some other site. So most BTK inhibitors are actually class 6. There's a typo there that says 1. It should say 6 there, and that includes the best known of them, ibrutinib. And these bind to cis481 residue, which is in the ATP binding site of the hinge domain. This is very poorly conserved among kinases, so they have quite high specificity for BTK. Their binding is covalent and irreversible on the whole, and that covers some of the older and some of the newer BTK inhibitors as listed there. Some of the other more recent BTK inhibitors are type 2, so they target the H3 pocket, which is a region adjacent to the region occupied by ATP. And what they do is they stabilize an inactive non-phosphorylated form. And interestingly, this seems that it may have a greater effect on the Fc gamma receptor and Fc epsilon receptor signaling. And some of those are reversible, like fenebrutinib, and some of those also have irreversible covalent binding that might result in a more sustained and potent effect. So to summarize that, so BTK inhibitors have likely or plausible valuable therapeutic effects in B-cell malignancies and B-cell mediated autoimmune diseases. But there might be other roles of BTK signaling to suggest other therapeutic uses outside of just blocking B cells and perhaps predicting some of the off-target effects. So there's now quite a wide range of these therapies that target this pathway that are in development that we're going to hear about in the next 2 talks. Thanks very much.
Thank you very much, Ed. That was a fantastic introduction to this relatively new pathway to us as rheumatologists. So great introduction. So I'm now going to hand over to David Eisenberg. So David's Professor of Autoimmune Rheumatic Diseases at University College Hospital in London. He was recipient of the 1991 Arthur Research UK Diamond Jubilee Chair of Rheumatology at University College. He's been elected to multiple fellowships, and his specialist area is autoimmune rheumatic diseases, particularly systemic lupus erythematosus, but also Sjögren's syndrome, myositis, and the antiphospholipid antibody syndrome. So David's going to talk to us about BTK inhibition in systemic lupus erythematosus. And David, the floor is yours. Thank you very much.
John, thank you for that very kind introduction, and thanks to Ed for setting the scene. I'm going to give a little bit of background to lupus to try and explain why we still are desperately keen to find better ways to move the therapies forward. So I'm going to assume that most people are aware of lupus being a clinical syndrome, a member of what I think of as the family of the autoimmune rheumatic diseases. It's a disease strikingly common in women compared to men by about 9 to 10 times. It's certainly more common in Black, South Asian, and probably Chinese women compared to Caucasians. And it has striking clinical diversity, matched at least apparently by its serologic diversity. At the UCL cohort, in the last 40-odd years, we've looked after over 820 patients, and I would point out that 14% of these patients have died. The mean age of death of those patients was 51 years. The mean age of death of a woman in the UK is 80 years. So for a lot of patients, we need to do a lot better. I mean, causes of death remain infection. Atherosclerosis in particular is much commoner in women with lupus than it is in other patients. Cancer remains a problem with some, with non-Hodgkin's lymphoma being the particular cancer that's associated with lupus. And in some patients, active disease still is hard to control. As I've said, the sex ratio is about 10 to 1. And the ethnicities in our group show that just over 55%, 56% are Caucasian. About a fifth of our patients are Black. About 13% are South Asian. The hospital is quite close to Chinatown, so we have over 40 Chinese patients and a number of mixed ethnicities. And in terms of symptoms, we are but humble rheumatologists, so not surprisingly, 90% of our patients have arthritis, over half have rashes, most of those are photosensitive. About a quarter of the patients have significant alopecia, recurrent crops of mouth ulcers, major CNS lupus, meaning epilepsy and psychosis, and about a third of the patients had biopsy-proven renal disease. And I suspect if we biopsied a few more patients, we'd probably find a few more patients with renal disease too. I think our understanding of the causes of lupus really goes back to our understanding of apoptosis, first observed in the modern era by Kerr in Australia. He referred to it as shrinking necrosis in 1971, around the time that he was moving from Australia to Scotland, where he studied, and he studied with Andrew Wiley, who became the professor of immunology at the University of Cambridge. And it was the two of them who first recognized that this term, which they changed from shrinking necrosis to apoptosis, is the major mechanism of normal cell death in complex organs, and it's characterized by a very orderly sequence of well-defined biochemical events. And you do not need to be a great histologist to see the difference between the viable cell on the left-hand side and the cell undergoing apoptosis. And the beauty of this is that it really gave us an understanding of one of the central mysteries of lupus, which is why lupus patients produce antibodies against structures buried deep within the cell. And it's because the nuclear fragments, these very dark fragments over here, are getting to the surface of the cell and are forming surface blebs. Now, the beautiful work of colleagues in Pittsburgh, Tony Rosen and his wife Livia, an experiment done 30 years ago, showed that human keratinocytes, which they were working with when subjected to ultraviolet radiation, this encouraged apoptosis and the formation of larger blebs and smaller blebs. The larger blebs containing nucleosomes, the larger row fragment, LAR and SM, the smaller blebs containing the smaller row fragment and other structures such as fodrin and Jo1. And it came to be recognized that under normal circumstances, cells undergoing apoptosis were detected, sensed by phagocytes in a very complex mechanism, which requires the C1q receptor, but also a variety of heat shock proteins. And under normal circumstances, these cells, these apoptotic cells, do not burst open. But when the phagocytes, as seems to be the case in lupus, are not working efficiently, the superficial blebs do burst open, releasing into the circulation nucleosomes and the Rho fragments and the La fragments. These fragments are picked up by antigen-presenting cells, which may be B cells, and through a complex interaction of cells, we produce the antibodies to DNA and SM and Rho and the rest of it. And for a number of years, in fact, if I'd been giving this talk 10 or 15 years ago, I would have said, well, look, we've got this great understanding now of how lupus comes about. And we know that there are so many different ways that we can interfere with these processes. We can block the antigen-presenting cell to T cell linked by abatacept. We can use tocilizumab to block the IL-6 receptor, all sorts of ways to block B cells, and the enhancing mechanism which incorporates interferon alpha. We have other drugs to do that, and it all looked very good. The problem was that when it came to the clinical trials, it began to look very bad. Even rituximab, which is now accepted as an effective way to go in the treatment of lupus nephritis in particular, with both the ACR and EULAR committees recommending it for the treatment of lupus nephritis, but rituximab failed its clinical trial results. Epratuzumab, anti-CD22, failed its clinical trial results. Abatacept failed its clinical trial results. We have, of course, some success with belimumab, and I'll mention that a little bit more in a second. Tabalimab, another anti-BAFF antibody, met one endpoint, or rather one trial was successful, one was not. Another anti-BAFF antibody, belimumab, failed to meet its endpoints. And atacicept, although it's undergoing a sort of resurrection at the moment, also failed its endpoints for a variety of reasons. So currently, all one can say in terms of drugs which have been around for a while is that Benlysta now is FDA approved and widely used. Rituximab is not FDA approved, but is still widely used. And everolimus is now FDA approved, but only for skin and joint disease. And NICE in the UK being far more conservative, because NICE really is about not so much whether the drug is effective, but whether they deem it to be cost effective. And NICE have approved only Benlysta. NHS England, a slightly shadowy organisation, does support the use of rituximab, so we do have that available. But when you contrast this rather limited list of drugs available and contrast it with the drugs available for the treatment of rheumatoid arthritis and psoriatic arthritis and ankylosing spondylitis, you can see how desperate we are in the lupus field to do something better. And that, in a sense, is where the Bruton kinase work came in. Now, fortunately, Ed has described a lot of what I'm going to say in the next 2 or 3 slides, so I can go through these very quickly. BTK is thought to function mainly as a linker protein for the recruitment of myeloid differentiation primary response, the MYD88. It's also, as Ed pointed out, involved in FCR signaling. And in this rather composite slide over here, it really makes the point that Ed was making, that it's clearly involved in a whole range of interactions incorporating cytokine receptors, antigen receptors, DES receptors, integrin receptors. But in particular, this is from the same, or the previous slide was the same paper as Ed was talking about, the important linkage to B cell receptors and the MYD88 over here. It's clearly a very central molecule in the development of B cell differentiation. So BTK inhibitors are increasingly used in patients with chronic lymphatic leukemia and mantle cell lymphomas. And as Ed has implied, the first attempts to use BTK inhibitors in autoimmune conditions are now being reported. There are a number of different inhibitors, and again, Ed has mentioned some of these. The type 1 to type 5 inhibitors are based upon their interaction with the ATA-PA binding pocket that he mentioned, or an active or an inactive kinase conformation, or by binding to a site distinct from the active site. There are also type 6 inhibitors, which form, as he mentioned, this covalent bond with the cis481 within the ATP binding sites of the kinase domain. And an example of this is ibrutinib. Type 2, which again he mentioned, I highlight particularly because I want to talk a little bit about fenebrutinib, of which we've done the biggest trial in lupus using one of these approaches. So here are just some examples of the way things have been going. And the greatest challenge here is, of course, to get the pronunciation right of these increasingly complicated names. Acalabrutinib, I particularly like. So ibrutinib, acalabrutinib, branabrutinib, evobrutinib, fenebrutinib, rilzabrutinib, and let's got that one right, have been used in a variety of autoimmune conditions. Ibrutinib in particular has been used, we'll be probably hearing about this from Stan, rheumatoid arthritis, lupus, multiple sclerosis, autoimmune heterogeneity, and Sjögren's. Acalabrutinib in rheumatoid, branabrutinib in rheumatoid, lupus, and Sjögren's. And I want to focus your attention on this trial of fenebrutinib in lupus. And to sum up what we know about the 2 drugs which have actually been used in clinical trials, fenebrutinib shows, and I'll demonstrate this, serologic but not really convincing clinical benefit Evobrutinib is safe, but there's been no clinical benefit noted, and we're waiting for the results of clinical work with these other two BTK inhibitors. So this was the study which I and colleagues published just last year about the efficacy, safety, and pharmacodynamic effects of fenebrutinib. And this was the trial. It's a pretty standard format with 3 arms, fenebrutinib at 150 milligrams, fenebrutinib at 200 milligrams twice a day, or the placebo. The placebo group, the fenebrutinib 150 group, or 200 milligrams BG group, in terms of age, you can see very closely matched. In terms of the sexes, closely matched. In terms of the different races and ethnicities, very well matched. And in terms of duration of disease, absolutely perfectly matched. So these are very good numbers of patients that were studied, and also very well matched groups of patients. The physician's global assessment, as you can see, also very well matched. In terms of the ANA positivity, anti-SM, anti-DNA binding, slightly lower than you would expect. Perhaps they're in numbers around 50%. In our group of patients, we have about 65% of antibodies to double-stranded DNA positive. Slightly low anti-C3 at 26%, 29% and 35%. In our group of patients, it's just under 50%. What's impressive is the number of BILAG A's. So these are pretty active patients, and nearly 50% are in the placebo group, and just slightly lower in the 150 milligram group, and slightly higher in the 200 milligram group. Remember, pretty active patients. So you can't say that we were treating inactive patients in this study. But here are the results using the composite endpoints, which I'm going to assume people will know about, the SRI-4 and the BICLA. And you can see, comparing fenebrutinib 200 milligram BD dose with the 150 dose and the placebo, there is no statistically significant difference. Likewise with the BICLA. Again, just a slight encouragement here, but again, it wasn't statistically significant, unfortunately. In terms of other endpoints were looked at, the SRI-6 response, again, there was no difference between the groups, and the SRI-4 with steroid tapering, no significant differences among the treatment arms in the SRI-6 response or the SRI-4 response with steroid tapering. In terms of the background treatments that these patients were on, again, no difference between the groups in terms of steroids, antimalarials, and immunosuppressants. But in terms of biomarkers, and I think this is the point that Ed was making, and it's one of the great frustrations, and we've seen this with atacicept and other drugs too. These drugs are clearly having quite a significant, I would say quite a profound effect on certain immunological parameters, but it's not kind of spilling over into clinical benefit. So just to sum up in the green down here, by 48 weeks, patients treated with fenebrutinib had reduced levels of BTK-dependent plasmablast RNA signatures. The antibodies to DNA were down, the total immunoglobulins and IgM as well as increased C3 and C4 levels, all relative to placebo. So the drug is clearly doing something, but somehow it just doesn't move into clinical benefit. And that's been the immense frustration. In contrast, these drugs, or this drug was at least safe. The frequencies of adverse events across all the arms are pretty similar, slightly lower in the placebo groups, but again, it's not statistically significant different. In terms of serious events, again, placebo, there were 8 events here, 4 in the lower dose of fenebrutinib and 12 in the slightly higher dose, but again, not statistically significant. So in conclusion, with the more specific findings of this particular trial, the primary endpoint was not met despite evidence of strong pathway inhibition through the demonstration of sustained decreases in levels of phosphorylated BTK, reductions in plasmablast signature levels, distinct changes in B-cell profile with reductions in immunoglobulin, including antibodies particularly to DNA, favorable improvements in complement levels. It was safe. And we said in the study that these offer insights into the pathology of lupus, and they might have the results and the way that the trial was set up in terms of redesigning for the trials. But unfortunately, this probably isn't going to be a way that's going to go. So in general conclusions, I would say to you this: the development of successful biologic drugs for lupus has been painfully slow. It lags at least a decade behind that for rheumatoid, psoriatic arthritis, and ankylosing spondylitis. We've had some recent successes with Benlysta and everolimus. They've given some hope, but clearly more is needed. Blocking BTK seems immunologically a logical approach, and there are a variety of BTK inhibitors now available, and maybe we've just been unlucky. Maybe the right ones just haven't been tried so far. To date, however, you'd have to say little success has been observed with the BTK inhibitors in lupus, and my concern is that we'll end up with what you might call a Freddie Mercury situation, meaning another one bites the dust. Thanks for listening.
Thank you very much, David, for a great presentation, very highly informative. Do put your questions in the chat. That's not you, David. That's for the rest of the audience. So if you've got questions, please put them in the Q&A, not in the chat, and we will have time at the end of the next presentation to address some of your questions. But it now gives me great pleasure to introduce Professor Stanley Cohen. So Stanley is Medical Director at Metroplex Clinical Research Center and Clinical Professor of Internal Medicine at the University of Texas Southwestern Medical School. He's also Director of the Rheumatology Division at the THR Presbyterian Hospital in Dallas, Texas. Stan is a past president of the American College of Rheumatology and also a past president of the American College of Rheumatology Research Foundation. In 2016, he was honored by the designation of Master of the American College of Rheumatology. And just last year, in 2021, he was awarded the ACR Presidential Gold Medal in recognition of outstanding achievements in rheumatology over an entire career. Now, many of those achievements were actually leading very, very pivotal and important clinical trials. And I'm greatly pleased and honored that Stanley is joining us tonight to talk to us about BTK inhibitors in rheumatoid arthritis. So Stan, over to you.
Thank you, John. Thank you for the kind words. Let's see if I can get the slides moving. So as we've heard from Edward and also from David, BTK inhibition for rheumatoid arthritis makes all the sense in the world. We know that based on this slide here, which shows what we all use in our lectures, for the pathogenesis of RA, B cells play a major role with ACPA formation. We have the myeloid lineage cells leading to cytokine production, mast cells, neutrophils, all of which have Fc receptors. So in theory, if we could inhibit these activities by BTK inhibitors, we should see improvement in clinical disease. And indeed, in the preclinical models of inflammatory arthritis, BTK inhibitors were quite successful. So there have been a number of BTK inhibitors looked at in clinical trials. And like David, my experience was predominantly with fenebrutinib, although we have participated in other clinical trials trying to inhibit BTK pathway. And shown here are the BTK pathways that are either in the public domain or available on clinicaltrials.gov with clinical trials ongoing, such as branabrutinib. Already discussed is the different mechanisms of BTK inhibition. Fenebrutinib was a little bit different. There was a reversible non-covalent BTK inhibitor, and whether that may have played a role in the one successful BTK inhibitor trial in rheumatoid arthritis is not clear. So I'm just briefly going to go through the data from this paper we published earlier this year. We're looking at fenebrutinib in a phase 2 dose ranging study, classical design, compared to placebo and an active comparator adalimumab in patients with inadequate response to either methotrexate or cohort 2, which was prior TNF inhibitor therapy. So in this study design, there were 3 doses: 50 milligram fenebrutinib, which was not felt to be effective, 150 milligrams daily, 200 milligrams BID fenebrutinib, compared to adalimumab, milligrams every 2 weeks in patients continuing on background methotrexate. Cohort 2 looked at the high dose fenebrutinib, 200 milligrams twice a day, compared to placebo. This is a proof of concept study. Primary endpoint for cohort 1 was ACR 50 compared to placebo for the 3 doses. And a key secondary endpoint was ACR 50 compared to adalimumab. And the study was powered for a difference for fenebrutinib to adalimumab. In cohort 2, fenebrutinib was compared to placebo. And again, ACR 50 was the primary endpoint. Study design, typical inclusion criteria. The TNF-IR population could have failed up to 2 TNF inhibitors. They had to have active disease at baseline, modest elevation in hsCRP. In this particular trial, they studied only seropositive patients to exclude the more difficult seronegative patients and have a more homogeneous population. Methotrexate in the standard dose was utilized, and corticosteroids less than 10 milligrams daily were allowed. Shown here is the patient disposition for cohort 1. If you focus on the bottom portion of the slide, over 90% of patients completed all the cohorts, either placebo, fenebrutinib cohorts, or adalimumab at 12 weeks. And for cohort 2, you can see 90 to 98% of patients completed 12 weeks of the study, the TNF-IR population. I want to point out the demographics. Typical age of rheumatoid arthritis patients, predominantly female. But again, like most phase 2 clinical trials now ongoing, at least in inflammatory arthritis, very few patients come from North America or Western Europe or the UK. The majority of these patients came from Eastern Europe or Latin America. And that's really what we're seeing now in clinical trials, and which makes it so difficult to develop new therapies for our diseases. It's a good problem to have with so many good therapies that we have to offer patients. Now, the disease activity was well balanced. DAS28 CRP was 5.7 to 5.9 for cohort 1 and 5.9 and 6 for the cohort 2. Doses of methotrexate were what we expect to see, 15 to 16 milligrams a week, and about a third to half the patients were on background corticosteroids. The majority of patients in cohort 2 had only failed one TNF inhibitor, 82 to 88% of patients. So here's the data. ACR 50 at week 12, percent of patients on the y-axis. And what you can see here is that the higher doses of fenebrutinib, excuse me, 150 milligrams daily and 200 milligrams BID were statistically superior to placebo, as was adalimumab. There was no statistical difference between the two higher doses of fenebrutinib and adalimumab in this clinical trial. In cohort 2, again, positive outcome. 25% of patients achieved an ACR 50 response compared to 12% on placebo, which was statistically different. Looking at the ACR 20, 50, and 70 in cohort 1, you can see that with adalimumab in blue here compared to the fenebrutinib in orange, numerically higher rates of ACR 20 and ACR 70 than the fenebrutinib group. But again, good results for the BTK inhibitor. But this did give some pause to the company developing the therapy as far as moving this forward in inflammatory arthritis. This is the data in the cohort 2, the TNF-IR population, 58%, 25%, and 15%, not too different from what we've seen with other TNF failure populations. One other factor that gave the sponsor some pause was the slow response rate, or the slower response rate. If you look at the hatch bar in blue on the methotrexate R graph, you can see that with adalimumab, there was a very rapid response, as we've known to expect. With fenebrutinib, the high dose, 200 milligrams BID, you can see that the ACR 50 response was delayed. It caught up by 12 weeks, but in the first 12 weeks, the response was somewhat slower. And this was another issue which raised some concern as far as continued development for rheumatoid arthritis. As far as safety, in general, as seen in the lupus data, the molecule was safe. There were numerically more grade 3 or more adverse events with the higher dose fenebrutinib and things that we expect, like pneumonia, pyelonephritis, one death from myocardial infarction, which is not felt to be drug related, and one zoster. In the TNF-IR population, very few adverse events or SAEs seen. And then LFT elevations were noted, and this was noted with other BTK inhibitors, and is something that if we do get one to market, that we'll have to monitor as we do with our other therapies. No other relevant, clinically relevant changes in red cell count, white cells, platelets, etc. Modest increase in serum creatinine, as we've seen with the JAK inhibitors, but no evidence of renal insufficiency. Now, looking at a couple other BTK inhibitors where there's some data in the public domain. This is evobrutinib, phase 2 dose ranging study, 390 patients, methotrexate incomplete responders. Primary endpoint was the ACR 20 at week 12. And you can see here at week 12 that there was a very high placebo response, 49.5%. And at the 75 milligram daily dose of evobrutinib, there was really no difference, 51%. And at the 25 milligram and 100 milligram dose of evobrutinib, slightly numerically increased rate of response, but not statistically different. And then there's been a great deal of interest in combining BTK inhibitors with JAK inhibitors due to the different MOAs that these molecules have. So this paper was recently published, and this was taking a look at upadacitinib, which is shown here in the dark blue bar, and ABBV 599, which is 15 milligrams of upadacitinib plus 60 milligrams of elsobrutinib. And so we had these combined in a molecule, and the hope was that we would see synergy a better benefit with the combination. What we have on the y-axis is the delta and DAS28 CRP. And what you can see is that the combination of upadacitinib and rilzabrutinib was no better than upadacitinib alone. There was no enhancement of efficacy seen. So this molecule is no longer moving forward, although others are still looking at this combination in rheumatoid arthritis. So if you're scoring at home, we have one positive clinical trial, and the rest of the clinical trials that have been published or presented in preliminary fashion have revealed negative results. Branabrutinib is still in clinical trials. So what do we learn? Well, first of all, we knew that these BTK inhibitors, new generation BTK inhibitors, were highly selective for BTK with little off-target kinase inhibition. Preclinical animal models suggested they should work. And based on preclinical modeling and PK/PD studies, pharmacodynamic studies, adequate BT inhibition was achieved at the dose of study. So it wasn't like we weren't getting enough BTK inhibition. PD markers with fenebrutinib, again, in the RA population, showed there was an impact on myeloid-enriched biomarker chemokine production and B-cell enriched biomarker B-cell chemokine. So there was a pharmacodynamic effect, even though, and there was a clinical effect with fenebrutinib as well in that particular trial. Fenebrutinib also demonstrated a reduction in IgM rheumatoid factor and total IgM and IgG. So the overall safety of BTK inhibitors is acceptable and comparable to approved therapies. So we have one positive study, which the sponsors decided not to move forward in RA, although they are moving forward in multiple sclerosis, as well as evobrutinib is moving forward in multiple sclerosis. Does the difference in BTK inhibition, the way binding occurs, does that play a role in the impact, which we just don't know. So we're somewhat confused, somewhat disappointed. We're happy to see this year's ACR meeting next week in Philadelphia as a presentation of data on a BTK inhibitor showing efficacy in Sjogren's. So I think there's hope still, but at this point, I don't foresee any of these BTK inhibitors being available in the clinic in the near future. So I'll conclude there and turn it back over to Professor Isaacs.
Thanks very much again, Stan. That was fantastic. Great overview. As you say, slightly disappointing outcomes here, but I think there's plenty for discussion. So could I ask the audience to put any questions you have in the chat, and we will move over to, sorry, again, in the Q&A, not in the chat, and then we'll move over to the Q&A. I've got a few questions anyway, and I'm sure the other speakers may have questions, but I'm really keen to hear from the audience if you have any specific questions from what you've heard. There is one question, David, about nephritis in lupus. In the trial that you headed, I didn't catch at the beginning. Was only lupus nephritis, or was this milder lupus? Is there any rationale to targeting lupus nephritis, would you say, with these drugs?
Well, according to some of the theoretical basis that Ed has given, the answer could be yes. My experience with pharma companies is they always end up doing two kinds of clinical trials in lupus, one lupus nephritis and one non-renal lupus. And the reason for that is that lupus nephritis is easier in the sense you've got these nice hard endpoints. You've got a protein creatinine ratio, a serum creatinine, you've got a biopsy, nice chunky things to play with. But of course, 60-70% of lupus don't have renal disease, so you've got to do non-renal ones as well. So this trial was of non-significant renal disease. It was focusing mainly on patients with skin and joint disease. I suspect that the company is not going to want to pursue this because the results, as I've said, in the skin and joint lupus, whilst some very intriguing serological and immunological changes and improvements, was not accompanied by clinical improvement, and that puts a damper on the whole thing, really.
Okay, thank you.
I might just sort of say that I think, because you and I discussed this before, David, that we sort of see the way things might be going in lupus. In lupus nephritis, you get all the damage in the first 6 months or 12 months or something. And so then if your first line of therapy isn't working and you start switching, you've lost too much ground. And we start to think from the trials we've looked at that the way things might be going is more combinations. People are even talking about starting with 4 or 5 different drugs at the start and then gradually stripping them down. And you could just sort of imagine that having another class of complementary classes of action could have some benefit. Not that necessarily will be commercially viable, but it sort of seems logical, doesn't it? That we know it could be hard for B-cell depletion to work enough on its own.
I remember as a medical student a very long time ago that the oncologists were never ever afraid to use combinations of therapies, and yet in rheumatoid, as Stan will remember, for many years, that the nostrum was use one drug, you give it a 6-month trial. If it fails, you stop it, you try one more drug. Now we recognize that combinations of drugs, certainly for rheumatoid, can be very effective, and I'm sure the same is likely to be true in lupus. Now in lupus, we now have 3 examples, 3 trials recently have been performed using a combination of Benlysta and rituximab, and at least one of them, the one that was done in the UK, the Beat Lupus trial, was highly successful. So yes, I think you're absolutely right. And now the challenge will be which sort of combinations, and that's another can of worms for us to consider.
David, I've got a question for Stan in a minute, actually. But David, you mentioned at the beginning, I think it was yourself rather than Ed, that these drugs have been used in CLL and some lymphomas.
Correct.
How do they work? Are they depleting, or are they? Do you know what the mechanism is?
I'm not sure. I'm not sure. I don't know the answer to that.
I think what you're doing, you're shutting off the survival of the B cells. Okay. So it's another, without B cell receptor signaling, BAF signaling, it does shut down their survival. Yeah, I
suppose that's what I assumed, and maybe I can bring in Stan here. I mean, in a funny sort of way, it's surprising they're not almost more toxic, because they're targeting so many pathways, and it looks like they might be killing B cells. And yet, Stan, you showed in that trial with upadacitinib, it absolutely made no difference whatsoever. I wasn't clear what dose was used in that combination tablet, but actually,
they used the highest dose they studied in combination. Wow. So the 60 milligrams. So it was the highest. Yeah, and again, this, at least with the PD studies, they showed that they were getting BTK inhibition. So it was not a subtherapeutic dose. So I'm curious, Ed, what you said. So you live in this arena. Why do you think we had a positive study with fenebrutinib? Did we just get lucky, or with contrast to the other BTK inhibitors, or do you hold much credence on the way the BTK inhibition mechanism might be?
Yeah, I don't know. I don't know really whether it's hard to say whether it's because, I mean, I work more in the lupus trials world, and one thing we're always saying is like, just because this trial's positive and this trial's negative does not mean that that's the right molecule and that's the wrong molecule, because we see all the time trials are negative for molecules that we think make sense and things. So I don't work so much in RA trials now, but I do sort of hesitate whether to say that because this trial was the positive one, that means that's the right molecule of all of this.
Right.
So, I just find it, I don't know.
I mean, your trial, Stan, looked very convincing. There was a nice dose response. So it clearly wasn't a fluke, but
what happened is that we pushed hard to let's confirm it, let's move ahead, let's do phase 3. But in rheumatoid arthritis, in contrast to lupus, we have a plethora of medications which are effective. And so from a business decision, it's a tough decision for someone to spend millions and millions of dollars to move forward, which is a shame. I mean, we still have whatever number 10, 20 to 30% of refractory patients who cycle through multiple therapies. I mean, I think drug design should be start with the refractory patients first and move back. But I'm speaking, people don't listen. We don't need another methotrexate incomplete responder therapy. But that's where we should start. And I'm disappointed that they haven't moved it forward. As they're moving it, they're in phase 3 trials in MS. So they clearly are committed to the molecule. So maybe they'll circle back and we'll see. But, in rheumatoid arthritis with the multitude of drugs and now the advent, you guys have had the biosimilar experience much longer than us, and we're about to have it. It's going to be, difficult to convince a lot of people to move forward with new pathways in RA.
Yeah. I mean, I guess, well, there will have been phase 1 studies that informed the dose. Again, I keep coming back to all these different pathways that seem to be or should be inhibited, and yet they seem pretty safe. In lupus, we're not seeing much of an effect. Part of me wonders whether the dose could have been even higher. I don't know about the dose in the cancer, for example, again, in lymphomas, whether a safer dose has been chosen because this is a rheumatological, rheumatological diseases. I don't know. It just seems curious to me how little we are seeing with them.
I do think the other thing I was thinking, Stan, was that in the RA studies, although the efficacy, the ACR responses weren't as high as you've seen in some studies, but this is always the thing, is that there are clearly some patients there who are having really excellent responses, aren't there? There's like,
Yes.
there was a bunch of people getting ACR 70s more than in the placebo, weren't there?
Correct.
Which it just makes you think, it's the age-old question, isn't it? Is there a subset of people where this is really the right drug for them?
Lacking treatment biomarkers, which we're all desperately wanting.
Yeah.
It's just this empirical treatment is difficult. But John, as far as ibrutinib in oncology, I think it's got a very, very nice safety profile, surprising. Okay. So, and again, my understanding of the clinical trial data, and David can tell me I'm right or wrong, but when I've looked at the fenebrutinib data and the evobrutinib data, they are getting over 90% BTK inhibition. At the doses they have, they're getting adequate BTK inhibition. So I don't think they picked the wrong dose, because clearly if they thought they had, they'd go back and do another study, because the safety was appropriate.
Okay, great. To the audience, please do send in your questions. I'm sure you've got some questions, or maybe you just like to listen to us discussing. I mean, we're happy to carry on doing this. I suppose the other answer then is there's just lots of redundant pathways, which has often been a hypothesis in our diseases, that just blocking, but actually even then, there seem to be so many pathways we're blocking. I'm really into, as Ed knows, I've got a passion about FC gamma receptors for work I did when I was in Leeds many, many years ago with Anne Morgan. And the fact that these drugs block FC receptors, to me, is of interest and potentially quite unique in pathways that should be really useful.
Blocking both B cell receptor and FC gamma receptor at the same time seems like it ought to be really good for some of these antibody mediated diseases, doesn't it?
Should be.
Is there a way?
I wanted to highlight the point that Stan was making about the challenge that we and pharma companies make about how decisions come to be made. And the decision which seems to be made around the BTK inhibitors is very analogous to what happened with atacicept in rheumatoid. So the company that was involved, Merck Serono, did a trial in rheumatoid arthritis where the results showed broad comparison to some of the TNF alpha blocking drugs, but just wasn't quite as good. So they decided really for business terms that they wouldn't proceed with it. They did continue a multiple sclerosis trial, which went badly wrong because that encouraged optic neuritis, so they stopped that. And then they got into the lupus world, and then are now about to, they've now passed the drug on to another company called, I think it's Vera Therapeutics, who are about to do another trial of atacicept in lupus nephritis. So we may yet see a resurrection of that, but the decision not to go ahead with rheumatoid was just because the standard said there's so many great drugs in rheumatoid arthritis, unless a new drug comes along that is substantially better, unless it's going to be substantially cheaper, it's not going to stand a chance. It won't go forward.
There's a question in the chat I'm going to put to Stan in a minute, but the other thing that you showed, Stan, was the slow onset of action, which actually is a little bit like rituximab, isn't it? So rituximab in rheumatoid, the maximum effect is about 12 weeks, which looked like the same here. And with rituximab, we're kind of rationalizing it, or I rationalize it as maybe it's an antigen presentation function of B cells, and that's why it takes 12 weeks to work, because you've got all the existing T cells have to die off or whatever. So I just wonder whether you're seeing something similar here, that it's actually more to do with antigen presenting function of B cells that's being affected. Anyway, sorry.
I don't know the answer to that, but I mean, clearly it is slower acting. Yeah. I was just curious, I spent a decade with P38 MAP kinase inhibitors. Where there, obviously a very important role in cytokine production, but there was ways to get around that pathway.
Yeah.
So I wonder if the same thing is possible with BTK. You've got so many redundant pathways that it has some benefit, but you can bypass it.
Sure. No, great. Quite possibly. Stan, there's a question in the chat which we kind of addressed slightly, but is there a rational reason for combining BTK inhibitors with JAK inhibitors?
Well, I do think there's a clearly different MOA. Instead of blocking the JAK isotypes and some cytokine formation, now you're also going to get B cell activity as well. So I think it does make sense to combine the two. And I think it was a very pleasant observation that safety was not an issue, in contrast to what we did 1,000 years ago, giving TNF inhibitors and IL-1 inhibitors together, or abatacept and TNF inhibitors. So combination therapies, the bispecific molecules, they're here to stay, and hopefully we'll come up with something that will provide some additional value with the similar safety.
Yeah, great. Question to any of you. What other diseases? I mean, again, given this plethora of actions of BTK inhibitors, you've mentioned, Stan, there's going to be some data on Sjögren's, which we definitely need drugs for. But any other thoughts? I think FC epsilon receptor was mentioned, IL-5 receptor. So is there a role in allergy, for example? Just inflammasome? Should we be looking at autoinflammatory diseases? I don't know whether anybody has any views on that. But,
well, I do know that fenebrutinib was being thought about or looked at, whether they went forward with it, with chronic urticaria.
Okay.
They were going to look at it there, and I don't know if they've done that or not.
I also wonder, again, borrowing from the world of CLL and lymphomas, is where, you know, there are situations in rheumatology where we feel you've got a B-cell mediated disease, but our B-cell targeted drugs just aren't hitting that hard enough.
Yeah.
And some sort of combinations of these different therapies might be needed to get in the most resistant, highest burden disease might be necessary. And I just wonder if there are roles there.
What, Benlysta plus BTK inhibitor, or?
Yeah.
Interesting. Okay. And safety looked really good, didn't it? I mean, we didn't seem to, which again goes back to my point, safety did seem good for drugs with lots of effects, and I guess you'd worry about off-target effects when it's doing so many on-target things, but
yeah.
That's why I wondered about the dose, but I guess it sounds like they're blocking the pathway, so you can't ask for more than that.
The only caveat is these studies were all short-term studies, 12-week studies, but the safety data did look good. There has been some concern about what will happen to immunoglobulin levels over time with longer exposure, but at least at the 12 weeks, the safety did look very good.
Yeah.
I mean, I was just thinking about what you were saying, John, about other diseases. The other interesting thing that always happens, isn't it, is where you've got an interesting therapeutic pathway and you've got it licensed for one disease, is that people get creative in the clinic when they have their difficult cases, don't they?
Yeah.
And you start getting reports where people notice really interesting uses. And I think the ingenuity that you come up with when you're in a tight spot with a difficult patient can be quite impressive. And I wonder if that's another direction to keep your eye on, is that people will realize interesting uses.
Well, they've got to be licensed first, Ed. So we've got to find a disease, yes.
So you'd think that something like myasthenia gravis or ITP would be candidates?
Yeah, sure. Listen, it's your last chance to put questions in the Q&A. We're going to close down in a minute or two. So if you've got any burning questions, now is your time to ask them. But otherwise, we'll just keep on enjoying ourselves and chatting amongst ourselves, because there's so much to talk about here. So, yeah, as I say, I think autoinflammatory disease, you mentioned rank as well. So maybe even in bony diseases, there's a role here. There seems to be lots of options if we can find the right disease targets. Would you combine with rituximab, Ed?
It makes sense to me in that we know that rituximab doesn't deplete well enough, especially in certain tissues. So it does make sense to me.
Great.
Yeah. And we know the combination of done this works.
Well, look, we're 59 minutes into this webinar, and we're meant to finish in 60 minutes. So I'm going to now say thank you to Ed, to David, to Stan, to the audience, to the Cytokine Signaling Forum. Please keep up these monthly webinars. They're really useful. And if you haven't found them, there's also a really good online resource that comes with the Cytokine Signaling Forum. So a really useful resource for all of us. So thanks, guys. Thanks to the audience, and see some of you in Philadelphia, but otherwise elsewhere. And before we finish, your feedback is really important. So we hope you've enjoyed the webinar, but would you please fill in the short evaluation form to let us know your feedback? And the live streamed version of this webinar is now available to view on your YouTube channel, Cytokine Signaling Forum. And the next forum is on the 7th of December, treating RA patients with special considerations. That sounds really interesting. So you can register now at that site. So thanks very much, everybody. Nice to see you. And
Thanks, John. Thanks, everybody.
Thanks.
enjoy
Bye.
the
Great
rest of
job.
the day or evening.